2 of the TPATH 2021 conference. This one is on resilience and strategies for navigating barriers to health and healthcare. And we're going to be hearing at least 2, hopefully 3 presentations because we had one presenter who at the last minute was unable to make it. So we won't be hearing from Dr. Ben Carroll as anticipated, but we do still have What is Working, Exploring the Positive Experiences of Transgender and Gender Diverse Adults with their GPs, that is general practitioners, in Aotearoa, I can never say this name right, New Zealand, by Miss Cassie Withey-Rila, who is based at the University of Otago Department of Preventive and Social Medicine in New Zealand. And they are a research student undertaking a Master's of Public Health in the Department of Preventive and Social Medicine at the University of Otago. Their thesis explores the positive experiences of transgender and gender diverse adults with their general practitioners in Aotearoa. Hopefully I got closer to it. After an undergraduate degree in English at Texas Women's University, Cassie was doing volunteer work as a queer, inclusive sex educator in Texas when they found their calling in public health. They generally find themselves involved in transgender healthcare access research and have a particular interest in exploring gender euphoria, strengths-based community work, and undermining the negative narratives around our communities. And I'll turn it right over to Cassie to kick us off, and then we'll hear from other panelists after that.
All right. Tēnā ko katoa e mihi ana aho ki ngā tupuna me ngā tupuna tāhine hoki. E whana mai au I Nota America ke ōtipoti toku kāinga I naine ko Qantas toku waka, ko Europe o ko tupuna I whange o ko tupuna te whenua o Tūraki Nota o America. Ko te naine tuka taku mahi ki ngā tanga whenua o era wahi. Ko kahi toko ingoa no raiera tēnei koto, tēnei koto, tēnei koto katoa. So what I've just said is in the native language of this country, Te Reo Māori, that I am originally from the United States. I was born in Texas. My ancestry is European, and I immigrated here to Aotearoa, New Zealand about 5 years ago. Just for the recording, I'm going to do a quick image description. I'm a slender white person standing with a white wall behind me. I've got long hair on top, and I've got black half-frame glasses and a sweatshirt that says "Trans People Belong." And in the background, there's a poster of the 2 islands. So just a quick overview of what I'm going to do. First, I'm going to see if I can screen share. Hopefully that works. Cool. So today I'm going to be talking about what is working, the positive experiences of transgender and gender diverse adults here in primary care at the University of Otago. It's been said before. I just want to acknowledge my supervisors, Dr. Kate Morgan and Associate Professor Gareth Treharn. They've been really helpful in all of this. I'm just going to check our poll real quick because I asked people what they wanted me to focus on more. And it seems like we have a bit of an answer there. Right, so I'm going to do a quick overview of the research project that I did for my Master's of Public Health. Then I'm going to talk about my results and kind of what that all means. And then hopefully we'll be able to allot most of the time at the end to the practical applications and like what clinicians and future researchers might glean from what I learned. So just a quick project description. My research question was about the positive experiences of transgender and gender diverse adults, specifically with primary care. Here in New Zealand, that means mostly GPs or primary care physicians, and that has to do with the way that they interface into the broader healthcare system because there's it's kind of a gatekeeping system, not necessarily in the pejorative term, but everyone must go through primary care in order to access other services. We really wanted to focus on the positive experiences so that we could inform best practice and future research with what works rather than what doesn't work. And as always, any more information and research on our communities is really important and potentially life-saving. Just real quick, I obviously am thrilled to have an audience where I don't have to explain who we are in our communities, but for the purposes of this research, I use the term transgender and gender diverse. And the way that I described that or defined that was anyone whose gender identity differs from the sex that they were assigned at birth, but I made that broad enough so that I could really specifically include people who had non-binary gender identities, a lack of gender identity, especially Native or Indigenous gender identities. So Māori gender identities such as Whakawahine and Tangata Iratane, just as two examples. There's a whole bunch of them that we wanted to make sure felt comfortable participating in this research. And we wanted to make it clear that it was of any gender expression with or without any medical transition experience. It was important to me when we were creating this definition, community group, that we really wanted it to be broad enough to capture all the different aspects of our communities. Real quick on the methods, I did a two-stage recruitment. The first part was an online eligibility questionnaire, which I circulated on social media. Then I did, from that pool of 30 respondents, I did 11 qualitative email interviews. They were semi-structured. And that was a really good opportunity because I was able to get interviewees from around the country, not just local to where I am, the bottom of the South Island. Then I analyzed the data using thematic analysis. And due to the under-researched nature of our community's qualitative methods were a really great way to get a deeper, more intimate understanding of people's positive experiences with primary care. My insider status is something I talk about a lot more when I'm presenting to an audience of cisgender people, but generally speaking, we all know that that really helps build a level of trust and understanding and common shared cultural experiences and language. So to talk about my results, I took my data from my email interviews and I did my thematic analysis, and I made this really great swoopy Zoom slide. So the first thing that really stood out was, even though I asked people specifically about their positive experiences with primary care, they all talked about, every single one talked about how sad the state of care was. So when I asked about their positive experiences, participants talked about how there were lots of barriers to care, how they felt uncomfortable with primary care physicians, etc. And there's a quote here that kind of exemplifies that. I feel like I'm mostly complaining about bad things rather than focusing on the good. I guess it's because it seems legitimately ridiculous just to type things like, it's been a good visit to the doctor because he knew more about medicine than me. And I think this is a common experience in our communities. We all have had experiences of having to play educator, and we shouldn't have. The next theme that really was of note was what I call the sphere of control. And this is just the fact that even though people talked about how disadvantaged they were or how many barriers there were in the system to accessing care, ultimately all the participants found creative ways to advocate for themselves, exert self-determination, and just generally make things a little bit better. And an example of that with this quote is, I could only get the bare minimum of care. I asked around the internet to try to find another general practitioner, and I had appointments with a couple of them, and the third was my breakthrough moment. So this is an example of a participant who had a history of not great experiences with primary care. And so they were self-advocating by going out on the internet, going to our community groups, probably Facebook, and finding recommendations from other people in the community on which practitioners might be safe for them to interact with. And then the final main theme is about the gradient of positive experiences. And this is like what I was ultimately searching for, was the experiences that people had that were positive. The ways that participants described their positive experiences was varied, and it ranged from very simple things like the doctor wasn't a jerk to me, all the way through to doctors who were advocates in improving transgender health outcomes in the communities or in their practice. The quote I have here says, "At my GP's office, they have posters on the wall about gender or sexual diversity, which is a positive because it lets me know that the staff will already have a basic understanding of trans people and their needs." And this was something that we noticed a lot. There's a lot of examples of ways that GPs or primary care physicians could signal to the patients that they were potentially aware of trans people existing or had an understanding of transgender health issues or might be someone that they were safe to come out to. So now that we've talked through those themes, my research matched the literature. There was a lot of examples in the literature of barriers to health, poor health outcomes, and health inequities, which we all know that. Most of the literature on transgender health is about those negative outcomes. When I was looking at the literature and when I was looking at my research, the sphere of control was really notable, and there was lots of literature that talked about that indirectly, in that they gave examples of transgender people, gender diverse people exerting control in their lives and making the best of an unfortunate situation. So that's something that I think is really of note, that, and even some of the presenters just here, I've heard talk about really good examples of that. And so this is of such note that I came up with a phrase or a term to describe it, which is reactive self-determination. And that's just a way of conceptualizing how our community, being socially marginalized on a systemic level, is pushing back against those systems in little ways that we can, little bits that we can find small ways to exert some control over our situation. And this is specifically in response to the systemic issues. I don't think that we would need to do these things if we didn't have these barriers to care. And so we can talk about that more in the questions if we want. The gradient of positive experiences, as I mentioned before, was quite a wide range of stuff. And the literature talked about that a bit also, is that there's just a real variation in what people can consider positive. Sometimes it's really, really small, simple things, all the way through to people who are doing quite complex advocacy work for our communities. So in the little poll I did, it sounds like people wanted me to mostly talk about the practical applications of this research and this recommendations that came out of it. So being in public health, we always want to operationalize or have practical applicability to our research. So I want to make a point right up front that systemic solutions are always needed to address systemic issues. So while I do have some things that GPs would be able to do practically, primary care physicians would be able to do practically to show that they're supportive to transgender patients, ultimately we need to address the systemic issues in order to have real change. So some of the things that came up that in both the literature and my research, basic professionalism goes a really long way. And this is just not making a face when you encounter a transgender person, all the way through just knowing that transgender people exist. So when someone discloses to you their transgender status, you know what that means. And that's something that gets taught in medical schools in the way that we do intake. Building trust with patients is something that's already taught. So it's really interesting to see how useful that can be for people. We want to encourage people to allow for experiential authority. Transgender people, as we all know, have just a wealth of knowledge and a lot of what's considered anecdotal knowledge, but ultimately the research always ends up backing what we know to be true up. So we want things to be evidence informed, but ultimately it's just codifying what we already know to be true. It's just legitimizing it for the cisgender academic or medical world. So collaborative relationships was something a lot of participants talked about being really meaningful for them, and it felt empowering, and they felt reassured that their doctor was going to enable whatever care they needed. And I encourage practitioners, trans or cis, to consider joining your union, because practitioners have a lot of power in medical systems, and I feel like that is an underutilized area for advocacy. So join your union. I encourage anyone that's thinking about going into research to really consider doing strengths-based frameworks and always make sure that it's informed by the community, whether that be about our communities or any communities. I think there is a lot of negative health outcomes in any marginalized community, but ultimately we are more than that, and we deserve to have all of our beings represented in our narratives in society. Some more big picture stuff. I would really like to see some changes in medical school curriculum, not just one-off modules or a single day of coursework where medical trainees are learning about transgender medical needs and medical transition, which obviously they need to know those things and that's important, but I would like to see instead a real foundational change in the way that we conceive of biomechanical ways of being and our biomechanical ways of thinking about health. And that is a big ask. I realize there's a lot to make that happen, but it's especially relevant here because of our treaty with Maori people. It demands that we have a bicultural system. Obviously that has not been upheld, but it's really important to make sure that we have in our medical schools both worldviews encompassed, and it would be really nice if more countries were able to include the indigenous worldviews into their medical school conceptualizations. So practically getting the information that we know to be true, the research that we've conducted to people who are actually working in primary care. I think updating best practice documents is a really good way to go. That's something that I intended this research to do. Best practice is preferably evidence-based, but as we've talked about in other presentations today, often there isn't enough data, there isn't enough evidence. And so obviously being community informed and evidence-based is the ideal, but if you can't have one, at least you have the other. I think continuing medical education and continuing professional development are both ways that we can improve knowledge bases for people who are already in practice rather than focusing on the medical school, which is doctors who haven't entered the workforce yet. And also centralizing pathways to knowledge, I think, is really important. There's a range of point of care information summaries, which are websites that doctors can access to brush up on a topic or to learn what kind of medical procedures are expected on a certain health issue. And that might be a way, if doctors in a country are broadly accessing that, either professionally or through an institution, they might be able to access best practice documents and other information about transgender healthcare. Also, and I know this has definitely been talked about by other people, so apologies, this is getting repetitive. The software that doctors use, the clinician-facing software, is often really limiting in its ability to accommodate transgender experiences, as in it doesn't allow for gender markers to be changed easily, or it doesn't have gender markers other than male and female, or it isn't capable of separating sex-specific screening reminders from the gender marker. And that would, an example of that would be if you change a gender marker from F to M, you are no longer going to be sending out cervical cancer screening reminders. And so that's a really big issue, not just for patient experience in that they're going to be constantly being misgendered by a system, and the doctor who is interfacing with that system is going to be, that's going to be in conflict with the person in front of them potentially. It's going to be confusing, and like then the onus is on the doctor to try to manage that. So getting software that supports the doctor and supporting the patient is really important. And then the larger ramification of this is that a lot of people who are transgender may have to make unfortunate decisions around if they want to leave their gender marker as it is to get those sex-specific screening reminders, or if they want to risk missing a reminder, but then having a more affirmed experience in interacting with their GP and the medical software. And that's also an example, I think, of reactive self-determination, these kind of decision-making processes that we go through that we should not have to make and absolutely are barriers to health. But ultimately, we're making a small decision where we can in order to improve an outcome. And even if that outcome is long-term negative, right now, we're not confronted with something that makes us uncomfortable. And there's a lot more to be said about that. And I know now that COVID is a thing that exists, improving telehealth options is something that I'm really, really passionate about. That's really important also for rural communities, under-resourced communities. People who have certain mental health conditions would really benefit from being able to access telehealth options. I'm trying to wrap this up quickly so we have as much time as possible for questions, because I can talk forever and I really want to know what it is that people want me to share about this research or my findings or reactive self-determination or anything else. Again, thanks to my supervisors, of course, but especially thanks to my participants for being able to give of themselves so freely and enthusiastically and help me be able to tell their stories and ensure that future people are able to access more appropriate transgender affirming healthcare. If you have any interest on more things about transgender existence in Aotearoa, there's some research from Dr. Jamie Veal that's really great. It's our first really big national level survey of transgender health and demographics. It's really great that we have that now. And my contact information is there in case anyone has any follow-up. I think that is me.
Thank you so much. I'm gonna go ahead and remove the pin off of your video so that you're no longer having to be front and center. And I am going to go ahead and share screen, and I will play a pre-recorded presentation from Dr. Zachary Dubois, which also involved Jay Puckett, whose bios I will read quickly. And their presentation is on resilience and health amidst COVID-19, experiences of trans and gender diverse people living in Oregon, Michigan, Nebraska, and Tennessee in 2020 to 2021. And Dr. Dubois is an assistant professor of anthropology at the University of Oregon, and unfortunately he's unable to join us. But after the presentation, he's instructed me to share his email so that you're able to contact him if you have questions. And I believe we've added him to the Whova platform, so if he is able to find a spare moment, he can check those questions there. And another co-presenter that was involved with this as well is Dr. Jay Puckett, who is an assistant professor in the Michigan State University's clinical science program, and they direct the Transilience program, the Transgender Stress and Reliance Research Team. So I'll go ahead and share. And we, at the end of that video, we'll end with one final panelist before we go on to the Q&A period. And we will have a Q&A period this time. Okay. Do a brief test. Can somebody, once I hit play, confirm that it's working?
Hi, my name is Zachary Dubois, and I'm an assistant professor in the anthropology department at the University
Was
of
that
Oregon.
working?
Yeah, that was perfect.
My
Okay.
pronouns are he, him, and today we're going to be presenting on trans resilience and health amidst COVID-19, sharing some of the experiences of trans and gender diverse people living in Michigan, Nebraska, Oregon, and Tennessee during the COVID-19 pandemic of 2021.
Hi everyone, my name is Jay Puckett and I'm an assistant professor at Michigan State University in the Department of Psychology. My pronouns are they, them. Okay, and as we get going today, we wanted to take a minute to acknowledge the many people who contributed to this study. This was a very big undertaking, and so we had many people involved, and it wouldn't have been possible without such a large dedicated team. So in addition to our co-authors on the first slide, we were joined by all the folks listed here who contributed in some way. If you'd like to find out more about our study, you can go to transresiliencestudy.com to find out more about our team and our methods. So given the existing research, we know that trans and gender diverse people are exposed to many hardships in life, such as encountering significant barriers to healthcare overall and to healthcare that is inclusive, as well as high levels of economic hardship and homelessness and high rates of exposure to violence and discrimination, as well as many other minority stressors that exist. We also know that these minority stressors have a significant impact on health and well-being. Past studies have shown associations with depression and anxiety in addition to suicidality, as well as risk for chronic disease. During the COVID-19 pandemic, these social inequalities have been exacerbated. This has included trans and gender diverse people reporting reduced income, high levels of job loss, as well as less access to health insurance. All of this, of course, has important implications for the already disproportionate health disparities in our communities. In addition to this, many trans and gender diverse people have reported reduced access to gender affirming resources during the pandemic, such as access to gender affirming healthcare, like hormones or surgeries, and many people also report spending less time living in their affirmed gender. This could be due to a variety of factors, such as living with folks who might not be affirming or less secure housing. This might particularly be the case for youth and young adults that might be more isolated and living with families that are not supportive of their identities during the pandemic. This reduced access to care and affirmation of folks' identities, of course, has implications for psychological distress, and we see that this can be associated with worse mental health. So although there are significant hardships experienced by many trans and gender diverse people during the pandemic, some people might also have experienced a reduction in exposure to some of the minority stressors as a product of just being out in the world less and having less interaction with people, even though, of course, that also means folks are experiencing more isolation. So in addition to some of the research that we've seen so far, there has been less focus on resilience during the COVID-19 pandemic. And so our study wanted to take a look at some of the nuances in folks' experiences during the COVID-19 pandemic and how resilience might be showing up in their lives. So in terms of the overall study, the study was conceptualized by myself and Dr. Dubois around October of 2018. And this is when the Trump administration was in office. So during that time, as we all know, there were a variety of policies that were being enacted that brought a sense of urgency for us, where we really wanted to study the effects of social political context on health and well-being for trans people, in addition to ways of being resilient in the face of these challenges. So these were our overall aims for the project. We wanted to document how shifts in social political context relate to shifts in stigma, resilience in both mental and physical health. We also wanted to describe the ways that trans people show resilience in the face of stress and stigma and how this might differ across contexts. We also were interested in how geographic location and local context shapes exposure to stigma, experiences of stress, resilience in both mental and physical health. So in order to achieve these aims, we recruited folks across 4 different states: Oregon, Michigan, Nebraska, and Tennessee. And we intentionally recruited in these states given the range of social political context that we're talking about. So Oregon has the most policies and protections in place for trans people. Michigan is kind of a mixed bag with some protections, but not others. And then Nebraska and Tennessee had the least policies in place and had more negative context for trans people. So in terms of our methods, participants were recruited through a variety of means, including online, through social media, community organizations, and outreach and in-person events, and snowball sampling. To be included in the study, participants first had to complete a screener, and after we reviewed that data, we enrolled folks in the baseline part of the study. And so for baseline, this involved a pretty extensive in-person visit where we conducted an interview lasted about an hour, about an hour's worth of measures and surveys that folks completed, and then biomarker collection. After the baseline part of the study, we then moved into online surveys for 1 year in order to see how the shifts in social political context related to shifts in health and well-being and resilience. And then we are now in the process of doing our final interviews and in-person biomarker collection. So The initial data collection for the baseline part of the study ended in March 2020, and then we shifted to the online data collection for the 12 months of surveys from April 2020 to March 2021. And, you know, this also aligns with the pandemic. So we initially had goals of a higher number of participants in our study, but given the start of the pandemic and everything, we went ahead and shifted to the online 12-month surveys as soon as that started. So that created a unique opportunity for us to actually look at some of this, the effects of the pandemic in our sample. So overall, we had 158 participants with an average age of 33 years old. Participants had a variety of gender identities, including trans men, trans women, genderqueer and non-binary participants, as well as many others listed here. Most of our participants had housing at the time of the study and were either employed or a student. And then, as is common in many trans samples, most participants had financial strain, with over half of our participants earning less than $20,000 a year. In terms of recruitment in relation to race and ethnicity, we ended up with a sample that was 69% white. And now I'm going to turn it over to Zach so that he can tell you a little bit about our monthly surveys.
Thanks, Jay. So after completing the in-person baseline interviews and biomarker measures, participants were asked to complete monthly surveys. So those started in April of 2020 through March of 2021. And in that COVID questionnaire that we developed for this project, we had 2 open-ended questions, as you can see here. And we conducted thematic analysis with 2 independent coders, iteratively generating the code book and applying those codes, resolving any discrepancies through consensus. As you can see in the table here on the left, the most commonly reported contributors to resilience and well-being described by participants focused on things outside of themselves. So we first broadly coded these as focus outward, applied that code to 1,184 excerpts from 149 participants. The emerging themes within this broad category are shown here in order of frequency, with connection being referenced most frequently, with 134 participants mentioning this 679 times over the year, for example. We defined our codes in the box on the right, so connection with other people or animals in ways that provide comfort or boost resilience. In terms of codes reflecting more of a focus outward, the next most frequently mentioned was distraction or immersion in things like nature, TV, film, games, books, really anything found to draw and focus attention in ways that were enjoyable or distracting from the challenging reality of the moment. We also coded excerpts of text where participants described focusing inward, so on oneself, with the most frequently mentioned of these being self-care. So these are behaviors that are found to be calming, soothing, or improving of physical or mental well-being. The figure here on the right lists the many other themes that we identified, reflecting what participants found contributed most to their resilience this past year. And when we examined these across the 4 states, so Michigan, Oregon, Nebraska, and Tennessee, where study participants were living, these 3 themes of connecting to others, self-care, and distraction or immersion were consistently the most common and referenced by the most people over the course of the year of data collection. We also learned how remaining busy with work or school, avoiding news and social media, accessing help like therapy was helpful to people as was making things and maintaining daily routines, practicing religion and spirituality, recreational and medicinal use of drugs and use of alcohol, and building new skills. you would expect, these different strategies intersect in a number of ways for people. So here you can see that 39% of the references to distraction and immersion included references to connecting with others, for example, visits and walks and venting sessions with close friends outside. So the participant, this participant is describing that intersection there. Similarly, 23% of the references to distraction and immersion included mentions of self-care. So here, for instance, where immersive activities like reading are described alongside calming practices of self-care like burning incense. So using mixed methods to drill down and make comparisons across subgroups, for self-care and connecting with others, we found similar frequencies across gender, age, race, ethnicity, relationships, and living situation categories. But when it came to distraction or immersion, half of the participants in each of these generational cohorts mentioned some kind of immersion or distraction, but we found differences in the type of activities that individuals described in each of these groups. And in these boxes, you can see quotes from participants summarizing these. Gen Z, so those participants that were 18 to 25, described immersion in video games. Animal Crossing was particularly popular, but there were no participants in Generation X or millennials who mentioned video games. Instead, those were much more focused on avoidance of media, both news and social media. Boomers were actually a mix and reflected a group that some were really engaged in social media and others also were in avoidance. Across the 4 states, as you can see here, the blue bars here are reflecting that showing that 30 to 55% of participants wrote about the positive impact of COVID mitigation policies and practices. The yellow bars are showing specific references to vaccine. But they're describing the positive impact that these had on their resilience and their well-being specifically. Most interestingly, though, are differences in how they discuss these experiences. So for instance, all of the participants from Tennessee who reference policies in some way are describing the benefits of working from home, self-quarantine, or as this quote reflects, controlling what I can, like going out infrequently, wearing a mask, convincing my husband to wear a mask to work, and not dwelling on things that I can't. So these are reflecting individual level focus and tensions around mask wearing, controlling what you can. Similarly, in Nebraska, participants mentioning individual actions that could reduce risk, making sure I'm not putting myself or others more at risk than necessary. I'm going out even less. This points to some of the increased potential for isolation and the risks associated with that. But when we compare these to Oregon and Michigan, where participants mentioned the benefits of their state's policies and approaches, so making sure having the ability to quarantine and get supplies safely in environments that are very pro-mask. Now, although we know there's a lot of conflict in vision within these states, as well in these regards, in general, these are showing that individual level impacts of some of the state level policies have. And this is not just through individual practices like mask wearing, but the real hope and optimism that these policies provide were referenced a lot in terms of our study participants' concerns. In terms of vaccines, for example, though, early in the study, all of the vaccine mentions were simply hopeful. they didn't yet exist. And then more recently, in the final 3 months of the online survey, these became more descriptive as people began to access the vaccine.
Unfortunately, just due to time concerns and the fact that the pace of that video was quite rapid, enough that I needed to slow it down in order for it to be interpreted, we don't have time to finish watching through the rest of it, but it is available on YouTube, and we'll make sure that that link is available to attendees so that you can see the remainder of it. We do have one final panelist, and then we will have a Q&A period for sure. So I will actually be switching to French momentarily so that I can read a bit about the organization that our next panelist is representing. Et bon, j'attends l'interprète un instant. Vous êtes prête? Bon, notre dernière présentation est par Simon Jutant, qui représente l'association Acceptess-T. L'association Acceptess-T est une association d'Île-de-France qui a été créée en 2010 par des femmes trans, migrantes, travailleuses du sexe et concernées par le VIH dans le but de lutter contre les discriminations auxquelles leur communauté était confrontée. L'association accompagne chaque année plus de 2000 personnes, en majorité des personnes trans, originaires d'Amérique latine, concernées par le VIH et le travail du sexe. Et je vais passer à toi, Simon, pour présenter. Et merci beaucoup. Just a second. Looks like we have to re-add Simon. Sorry. And Simon, c'est prêt?
Oui, c'est bon. Bonjour.
Alors, dis-moi.
Est-ce qu'on m'entend correctement? Alors, je vais essayer de partager mon écran. Voilà. Je devais ce soir présenter avec mon collègue Laszlo qui n'a pas pu être là. Donc je vais présenter.
I would like to make this presentation with my colleague.
On souhaitait aujourd'hui présenter une action qu'on a mis en place en 2020.
We would like to present this action that we implemented in 2020. This is a prevention, an online prevention action. I would like to thank you for this invitation. The presentation you will now see, as we have presented it before the AIDS committee, so there will be an oral presentation, and also you will see my screen. I will try to explain what you are seeing. This is why it's important for you to leave it as is so that you can really understand the action context where we have evolved as an association in France. The association is autonomous. It has a platform as well, and it can implement different actions. This presentation will have very simplified visions. That's why it's interesting to make this interpretation today. It is a way to reflect. As an autonomous trans association, we need to put our ideas into practice in order to justify them and maintain them over time. So in this context, our presentation, my association mainly works with Latin America and people with AIDS or HIV. It has evolved, the association has evolved quite a lot. 10 honorary trans people work for the association. They are mainly trans people from Latin America, and they're mostly sex workers. And we help them with their social rights, with housing as well. So the association actually started working on prevention since the beginning of 2019. We have a coordinator for health mediators and approximately 10 volunteers. There are 3 main intervention pillars. There are some actions that are external, or let's say outreach actions, community actions, HIV tests are run there in those visits. And if they are positive, we try to help these people. We provide them with advice in the field of health. We try to do so comprehensively so that we can help people in this area. These can be trans people with HIV positive, also other types of people. This action was launched in 2020. There was a full lockdown between March of 2020 in France, and then there was a second lockdown later on in November of 2020. These measures had a strong impact on our sex work, and they have had a huge and dramatic impact on the living conditions of sex workers in France, because they live and work in poor conditions. Therefore, the association found it impossible to go around the country to help people and to follow up on the people we usually see. Therefore, we implemented an online prevention strategy on trans meeting sites and on our social media. We also included a line on financing that allowed us to develop this action. This is a challenge we needed to face. We need to understand that this action takes place in a very difficult context, and it's very difficult for us to negotiate. Objectives of the action: to disseminate information on health prevention regarding sexual risks. Also, as I said before, we followed up on people who had been removed from the system, also around the topics of HIV and COVID. We needed to work as well because we had the opportunity to show people what the condition was as sex workers because of the lockdown, and also the living conditions in this crisis moment. We also showed them, or tried to help them how to implement this prevention strategy. It's always quite a challenge to find donors. And to overcome this obstacle, we worked with companies that help and contribute to all our actions. And we also focused on sex workers and those who are transitioning as well. We provide psychological and financial support. So the idea is to build a trust bond so that people would feel free to ask us anything they wanted to ask, so that they would feel comfortable as well. Here, this is a screenshot that shows the type of exchange that we usually have with people online. We are, for instance, this is a trans member that doesn't want to run the risk of contracting HIV/AIDS. So we need to keep working on xenophobia and sexual health.
I will try to speed up. My presentation is quite long. On screen, you can see the kits containing tests, HIV tests, condoms, lube, alcohol rub, face masks, and flyers of our organization. In addition to this prevention strategy, the people that we support for HIV testing are trans people in general, most of them sex workers, and 1/3 of sex workers are cisgender, in general, immigrants, and an average age of 32 years old. In drafting this strategy, we were not able to reach out to a portion of the trans community due to their isolation, and of course, we would have preferred otherwise. Clients who were involved between January and February 2020, we tested 1,500 people, and 130 people answered or reached out to us, and we sent them the care packages. We had, as you can see, 31% cis men, 33% trans, 2/3 living outside Paris, and they were anonymous. They did not submit their addresses or location. So they cannot be contacted. In terms of recreational use, 25% are sex workers and others are partners or clients. Most of the surveyed people are French, 91.9 speak French, so they can understand what we're saying, we found a lot of transvestites. And what I had said, we are addressing this population through our action. We use quite an arbitrary definition as to people who we find through this action. It is essentially people who for this population, anonymity and confidentiality are essential aspects. And therefore, we have the possibility to provide them with information about access to health care and sexual and reproductive health. We only have 5 minutes left, and then we will go to the Q&A section. The aim of this action, we reached out to 100 people whom we sent them a package after they tested positive for HIV. The people that had tested positive were then referred to the healthcare providers, and a lot of people came to a center or a clinic they already knew, although they did not have access to healthcare. Let me skip a few slides. So in order to reach the people that we wanted to reach, we use the image of our association in France and issued communication that would go beyond the people. What I mean is that we wanted the people to check the time that had been invested, 50 hours a week in different people, allocated to different people to address their sexual health. 25% people had been contacted who at the same time had their partners or clients and they were transvestites. And our conclusion is that we were able to transfer the on-the-ground experience to the online world, and we were able to reach out to those people in our community who are more isolated, but at the same time are more widely exposed to HIV, and they need better follow-up as they are in precarious conditions or they are still in the closet, and they need to have a closer monitoring or follow-up. There's also an issue about means and resources. And another aspect that we are interested in is the wider population. I think that this could be part of the discussion. The Trans Association, for the past 10 years, we've been advocating for prevention and actions that target trans people in particular, their clients and their partners who are relevant stakeholders, of course, in the transmission of the virus, and there are other awareness raising programs in the healthcare system. We should also consider those people who are more isolated, not only from a geographical standpoint, but social standpoint. They should be included in our actions to see what is the more adequate prevention approach for them. I've tried to provide as much information as possible in the little time I had left. I'm so sorry if I went too fast or if I missed anything in particular. Thank you. Thank you very much for your presentation. I will now switch to English for the Q&A, and thank you very much, Simon.
And thank you both. And thanks also to Dr. Dubois and Dr. Puckett for their presentations as well. I can see also that Cassie has been very busy answering all sorts of questions in the Q&A function already. All 4 of them were answered. So we have plenty of time in the remaining 12 minutes for more of an open discussion. And what I'll do, since Dr. Dubois, who was the lead on the pre-recorded presentation, since he can't make it, he's asked me to share his email, and anyone with questions is able to contact him directly that way. So you should be able to see that in the chat. And what we'll do, since all the written in questions, it seems like have already been addressed, if attendees would like to raise their hand, then I'm able to give you permission to unmute, and then you can pose your question aloud if you like. And I'll give that a second for folks that might have questions. And then if not, I will have them. I'm sure my co-organizers will have some as well. We're also at the final presentation of the day. So I'm aware that depending on where people are in the world, what time zone they might be in, we might be lagging a little bit, and that's totally fine. So if we aren't getting questions directly from attendees, I'll open it to my co-organizers if they have questions. I don't want to jump right in and like dictate where the conversation is going to go. Félix.
Je vais poser une question en français, j'attends pour si c'est OK pour l'interprétation. Ouais. Je peux poser ma question. OK. Tu as dit que la présentation, pour Simon, la présentation que tu as montrée, elle était
You
faite
said that the presentation you showed was actually targeting the cis population and what they would do to obtain what they wanted in that sort of contact. And another question, it's a bit more open-ended, is whether you have thought about different actions to reach that target population, the population that you had issued these questions to. I might be able to answer in English. Do you think that'd be easier? You can answer in English or in French, whichever one you prefer, because there is simultaneous interpretation. So it doesn't matter which language you would rather use.
Okay.
I mean, you can do it in French if you want, that's fine. What we had to do, I mean, the changes that we needed to make for this presentation were made by considering the health issues, the global health issues that I am convinced that unfortunately there are very few public agencies that actually address the trans population because they really don't care about it, or that is the main argument. that is present in public health care in general around the world, and the transmission that, that affects the global population. It is sad, but that's really the case. That's what we face every day. It's not, we many times are denied access, and that is a reality that we cannot hide. We can also wanted to know about the fight against HIV. And the second, the second adaptation, we needed to conceptualize the reality that we believe there are fewer categories that, and we needed to provide a framework for the transvestite community and include in this framework those who are transitioning. So these are different aspects where we also need to consider the health status of the population as well when it comes to transition and the health status of people. I don't know if, it's not really easy to explain. For the second part of your question, or your second question, we tried to do online work. It takes a lot of time to do so. And also go on social media. We also had to post the kits, the aid packages, and that requires collecting a lot of information, the community, and also ongoing and continuous training for our organization, for our volunteers. So it really does require a lot of work.
Thank you for the question. I have one myself, and I'll make sure interpreters have a moment to reconfigure. So my question is really for both of you, and it's also something I'd pose to Dr. Dubois and Dr. Puckett as well. Something I feel like I noticed in both your presentations, Simon and Cassie, is that it almost seems like both of you are doing research or providing services in different cases that are trying to fill the gaps that are left by existing systems or existing programming within the health system. And I'm curious if you have thoughts, and this may be kind of a political question, but I'm curious if either of you have thoughts about what responsibilities, what role the government has or should be playing in your specific national context or more local context in order to meet these needs. Like once we as trans researchers, we as trans service providers or as activists are able to say, this is a specific issue, this is a need that the community has articulated, and we try to communicate that, do you feel like that does create a responsibility for our governments? Do you feel like it should? Do you feel like we shouldn't trust them to meet those needs? I'd love to hear either of your thoughts about that.
And I've talked like so much time, so go ahead.
Sorry, I'm a very not tech savvy millennial. That's a great question, Avery. And yes, I am working to fill the gaps. That's why I did my research, is that there's the research in this area. Our communities knew that we were underserved here in New Zealand, and my experiences back in the States before I immigrated was that our communities were underserved. And here, until Jamie Veal did the Counting Ourselves study, we really didn't have any like real data on whether or not people were able to access healthcare services and how comfortable they felt with those services and stuff like that. I want to say that I think that the government exists solely to support the people. And so they absolutely have a really significant responsibility to provide care, especially for those that are most marginalized. Equity is really important for justice, and I care about that. And I don't know how to make people care about that if they don't. But I also want to acknowledge that in places like the United States, there is a really long history that explains why people don't trust the government. And so there's a lot of tension there in between. The government really needs to do stuff to take care of the community, but also the community doesn't trust the government as far as it can throw it. So, sorry, translators. So yeah, just trying to sit in that tension, I guess. The more faith the people have in the government, the more likely they are to have faith in the services the government provides and push for those services and feel like they're entitled to good services and that the government's the way to access those services they are entitled to. I think that's all I have to say about
that. Je vais répondre en français.
I will reply in French.
Ok. Pour nous, il y a deux parties dans cette
I think there are
question.
two sides to this question.
Il y a d'une part la question
On the one hand, we should provide the community and trans organizations an opportunity to support and develop their own experience and know-how. It is a process that is ongoing and it is developing in France at least. So there's been some progress. It is slow, but there is progress and it is evolving. But there cannot be one thing without the other. I mean, if there is no autonomy or if the responsibility only falls on the hands of the organization or associations, they would be fulfilling the role of the government, the role of the state. So politicians or government would no longer be accountable. In Europe, nowadays, there are more conservative parties, there are more conservative movements and more gatekeeping in healthcare. In France, for example, not everyone has access to healthcare. There's great inequality and there is no access to healthcare or rights. Especially trans people with no documents. And that really poses a great barrier in accessing healthcare and employment, really. If we look at the healthcare access of sexual workers, many times they do not have papers, we have missing information. And as I said before, we need to provide support to trans people and trans community. And I think that's a reality around the world. And it's not just about the trans community. Politicians are not really very savvy in how to support the LGBTI community. There's a lot of problems with undocumented people, people who are marginalized, and there should be changes in policy that is not just about the trans community in France.
Okay. Thank you so much for both of those responses and for both of your presentations. Unfortunately, that's the end of our time for this panel. And it's the end of our time for the second day of the conference, actually. So congrats to everybody for making it through day 2. We're looking forward to seeing everybody back tomorrow. Some quick things to note. Please do remember that the interpreters are working on relay. So the central language is actually Spanish. So I've seen several messages, largely from monolingual Anglophones who are saying, oh, interpretation's not working. Oh, never mind, it is. Yeah, it's because there's a little bit of a delay. Things in French would need to be translated into Spanish, then an interpreter is listening to the Spanish to translate that to English. So if you experience a delay, that's why. Please try to be patient. And let's also try to limit the use of the chat. If it's a direct question, let's add it to the Q&A, either on the Zoom or on Whova. That will just make sure things are more accessible. And we've got some co-organizers who are and multilingual, who are trying to translate things on the fly. And we're very, very grateful, trying to make sure everybody can participate as fully as possible. And yeah, thank you so much for these presentations. I feel like I learned a lot about two contexts that I don't work in, that I don't know much about. So I'm really grateful. And I'm looking forward to seeing more coming from both Acceptess-T and also from Cassie with their research. And thanks for joining us, everyone.